Good morning. It's 7:45 a.m. Yes, this is happening. You guys are great for getting here. I know people are still trickling in. I just want to welcome you formally to Ethics for Mental Health Professionals, or practitioners. I keep changing the name, so either one will do. We're briefly going to hear from Christopher from the Education Committee, and then we will get started with our session.
Yeah, just how you all wanted to start your conference with updates from the Education Committee. So that time has finally come. All right, so who we are, the Education Committee, it's a group of both adult and pediatric specialists. We're a multidisciplinary group, and I guess of interest to this group, we include both a psychologist and a social worker as permanent members of the CF Education Committee. It's a 3-year term, so we just will be adding a new social worker starting at this NACFC for the next 3 years, and my term will expire in a year. So if you're a psychologist and you're interested in this, be on the lookout for applications for the Education Committee over the next year. And that will come out on the listserv. Here's our list of the current members and the new members that will be transitioning tonight at 8 p.m. when we have our Education Committee meeting to make a nice full day for everyone. And we also have several really helpful liaisons from the CF Foundation, Lily LaFemina, Melissa Chin, and Paula Lomas. What we do on the Education Committee is just ensure that the education materials that are available to people with CF, their families, and the care centers are accurate and of adequate quality to be used across the continent. So we review materials periodically for their applicability, their accuracy, and we're starting to focus more on things like appropriate reading level for patient-facing, family-facing materials. At times, we'll identify an actual need and solicit materials from authors or just prioritize review of certain materials. And then we also review and select the education abstracts for the poster hall here at NACFC. So here's some of the stuff we did this year. We went through a couple of the components from CF Rise, which many centers use to help with transition, which you should be available to you on cfrise.com. We also reviewed the CF-related diabetes manual, which is now available in Spanish, and the Introduction to CF book for patients and their families, which is a multi-chapter book, and it should be, the new edition should be published next year in English and Spanish. You also hopefully saw, I know I sent this out on the CF Psych listserv, the CF Education Resources Guide, which it's also available in the my.cff.org resource library, where there are tons of resources. If you haven't gone there and perused before, there's a lot of stuff I wasn't aware of actually until I got onto the Education Committee. But this resource guide really provides kind of a broad overview of the sort of existing resources in CF that might be of interest to you. So if you can't find a resource you're interested in, do go to the my.cff resource library. There is a search function. There's also things that show you what's hot, the exciting resources that are out there for CF. And you can always email resources@cff.org if you're having a really hard time finding things. And you can also order hard copies. This is something I was not aware of either until a few years ago. So if you go on my.cff, go to order forms, and you can get those for your clinic, which can still be helpful for a lot of patients to have something in hand, not just a website to go to. So if you get stuck in that process, you can always email resources@cff.org. So what else you can do as you leave here? submit educational abstracts for NACFC. So that is one of our poster sections that we have in the poster hall. If you do any type of educational intervention, quality improvement project, that would be a time to disseminate that data. We may periodically send out needs assessment surveys to see what educational gaps we have in resources, so please respond to those. If you come across a material on my.cff that is outdated, we're finding a lot of things need to be updated that were developed pre-2019, please let us know, and we will either review that or remove it altogether. And then, of course, you can distribute the materials that already exist and submit your own resources. If you've developed something really cool and helpful for patients or care centers, please let us know, and we'd be happy to review it and sort of elevate it to the CF community. So that's all I have, and I'm looking forward to the session.
Thank you, Christopher. For those of you just coming in, so that was our Education Committee update. Thank you so much. We haven't started our session yet, so you're good. There are still quite a few seats up here. If you have bags on the chair, if you're saving a seat, that's fine. But if you guys have space at your table, can you raise your hand so people know you guys can, don't be shy, come in, eat your breakfast, get your coffee. There's several seats at the very front. And there's lots of seats. Come in, don't be shy. You made it here. You should be able to sit. You've made it here. And again, good morning. You are in the right session if you're looking to hear about ethics for mental health practitioners. And if you just happen to land in this room, you're welcome to stay as well. But seriously, yeah, there's plenty of room in the front. Don't be shy. So again, good morning. I'm Kimberly Moore, social worker from Children's Hospital Los Angeles, along here with my co-chair, Dr. Diana Naranjo from Stanford. We are very happy to welcome you to this discipline group session. We will be exploring ethical issues encountered by mental health practitioners such as psychiatrists, social workers, psychologists, and those who work with practitioners such as Jessica, our genetic counselor. And welcome to any other disciplines that are here as well today. We're hoping to highlight many of the ethical roles, responsibilities, and considerations faced in working as mental health practitioners or with mental health practitioners in the CF community. I'm just going to remind you, we have 4 speakers. Unfortunately, Dr. Schur cannot be with us. She was gracious enough to record her presentation. So we're going to start by listening to hers. And then we have our 3 speakers here, Siri, Jessica, Natasha. We will have Q&A at the end. Most of you know this is old hat. But for those of you who don't, if you have the app, and you're in this session, there's a Q&A portion where you can enter questions as they arise, whether it's during Dr. Sher's presentations or any of the others. Deanna and I will see them. We'll try to get to as many questions as we can from the app. And then if there's time, we can open it up to the floor as well. So we're gonna save those questions for the end, but please, as you're thinking of them, enter them in or make a note of that. Sound good? Okay. So I would like to introduce Dr. Schur, again, Sher, who couldn't be with us, but we're very grateful for this recording. So Liza Schur is a physician and professor of psychiatry in the Division of Medical Psychiatry at Stanford University School of Medicine and serves as the Director of Psychological and Psychiatric Services at Stanford Adult CF Center, where she provides psychiatric care and therapy to patients. She is a consultant to the lung transplantation program, and her area of research is on CF-specific cognitive behavioral therapy. Oops, nope, sorry. I knew I was gonna.
Hello, everybody. I'm so sorry that I'm not able to be there in person, but I'm so glad that I'm still able to present on this very important topic. And thank you so much, moderators, for inviting me to be part of this. So I will be talking about ethical concerns related to risk-sync and transplantation. And I'm Elizabeth Scher. I'm a clinical professor of psychiatry at Stanford. I'm embedded in our adult CF program. And also, during my last 12 years, I've been a consultant to our lung transplant program. where I see patients, when they're being evaluated for lung transplantation and provide psychosocial evaluation. I hopefully get them ready when they need some additional mental health support prior to, and then I see them in the hospital. And then I see many patients for many years afterwards, 1 year, 2 years, 5 years, 12 years. So I do think that over these years, hopefully I have developed kind of a perspective of seeing what this journey is like and what our patients go through. All right, so in terms of my disclosures, I do have a grant from the CF Foundation as part of the CF implementation grant. And also I do want to say that I'm a co-creator of Stanford Integrated Psychosocial Assessment for Transplantation, SIPAT, that is being used for psychosocial evaluation in hundreds of centers around the US as well as internationally. This was one of my projects as an mentees was the creator and my mentor and boss, Dr. Maldonado, when I was a fellow in the Young Attending. So objectives for the session will include, we'll talk about the ethics, kind of the ethical principles evoked by psychosocial evaluation for transplant. We'll talk about domains evaluated in psychosocial evaluation and why. We'll definitely talk about the inequities in psychosocial evaluation and listing and outcomes. And we'll kind of finish up thinking about how does it all come together and where's our role? How can we help moving this field forward? So first of all, how are patients selected for transplantation, right? Of course, there are medical criteria for each organ. And patients undergo a really thorough medical evaluation when the need comes. They need to be sick enough to benefit from this serious surgery when they switch one chronic condition to another chronic condition. But they cannot be too sick when they cannot tolerate the surgery, right? They cannot benefit and recover from that. And then each organ is being, of course, listed according, to its own tool. In lung, we have a new, waiting list tool, composite allocations forecast, which was changed from LAS, lung allocation score in March 2023, with the hope to improve outcomes. And then each other organ has its own tool as well. At the same time as the medical evaluation is being done, psychosocial evaluation is also being done. It's required by UNAS. It's not exactly specified what should be evaluated by UNAS or by whom, but every center is supposed to and is doing psychosocial evaluation. And usually it starts with the dedicated social worker, transplant social workers, and then in the more complicated cases, they escalated to transplant psychologists and or psychiatrists, and this is where I often come in. I also want to say that when psychosocial evaluation can help to decide whether somebody is a suitable candidate or not, whether they actually going to benefit from the surgery or not, and be able to undergo and withstand it. But once somebody's listed, they're listed based on the medical criteria and medical necessity, not psychosocial evaluation. So where they're on the list is not determined by the psychosocial evaluation. Sometimes patients might ask this. So what are the ethical principles guiding psychosocial evaluation? And kind of before I say this, I want to say that especially as a fellow and as a young attending, this was not a fun part of my job. That was still not a fun part of my job, right? It seemed to kind of, when I started doing the evaluations, it seemed to me kind of judgmental and, I didn't want to hurt somebody, right, by my evaluation. What I realized though, that this is an important part of actually protecting our patients. Because, right, it is a very serious intervention, right? Recovery is really difficult. Complications can and often will arise. And being psychosocial ready is important for somebody to actually benefit, right, from this intervention. So, but distributive justice, of course, is important. How do we choose transplant recipients, right, the right ones who can benefit the longest? Even the demand, right, outweighs the supply of the scarce resources, right, the human organ. And the transplant journey is challenging. And then we also, again, as I stated, evoke beneficence and non-maleficence. We're not just advocating for the organ, right, or for the program when we're doing this evaluation, but we actually are protecting our patients. I often find that I provide further informed consent during the psychosocial evaluation, making sure that our patients really know what they're agreeing to, and they want this, and they do have the resources. And these principles are mirrored by the recent paper published in 2021, the most recent consensus document for the selection of lung transplant candidates from the Journal of Heart and Lung Transplantation. They usually update them every 5 years or so. And again, like they talked about the principles of utility, maximizing the net benefit for the society. Nobody's kind of judged on their whatever we think is right kind of value, but we're really thinking about how can we maximize the society benefit, meaning that the organs can last the longest. We're thinking about justice. How do we evenly, right, kind of how do we justly distribute the benefits and the burdens of organ allocation system in a fair way? And we're thinking about respect for persons, right? We treat them as autonomous. They should be able to consent, right, to this treatment. They should be able to say yes or no. And in terms of like what goes into the psychosocial evaluation, this definitely has been studied, and the multiple studies are ongoing. But one of some very important, authors and researchers and clinicians in the field, Dr. Dudu and others, Dr. Dudu from Pittsburgh, published this paper in 2018, when they really, they provided consensus recommendations on the content of psychosocial evaluation of adult cardiothoracic transplant candidates. I want to say that this applies not only though to heart and lung patients, the same psychosocial parameters would be evaluated in liver or kidney or other, candidates as well. Like, of course, we're looking at treatment adherence and health behaviors. It's important to be able to take medications such as immunosuppressants on time. It's important to reach out, right, to providers if something is not going right. I would argue it's even more important than in CF, right? Because somebody might forget or not take immunosuppressants for a few days, and it might trigger rejection. So adherence is really important. And there's multiple things to adhere to, right? Appointments, lab draws, being hospitalized, medication, exercise, rehab. So there's multiple layers. Mental health history is important. We know, for example, of course, patients with CF have increased risk of depression, anxiety, but same is true for other lung transplant or other transplant candidates who come into this, right? People with chronic medical conditions do have increased depression, anxiety. We know this. So it's not about judgment, but it's making sure that it's treated appropriately and patients are connected to the right resources, right? If somebody's struggling with suicidality right now, we do need to address it. People, we can recommend them to be listed. Substance use history, and of course, it's even more important in some organs or others. If we evaluate somebody who has, for liver transplant, who has, alcohol, use disorder, and they're still actively drinking and they're not in rehabilitation, we can see how they're not going to be benefiting from the liver transplant if they don't develop the insight and the tools to abstain, right, and to get better. In the other factors, right? Cognition, knowledge and understanding of the current illness, knowledge and understanding of the current treatment plans. So again, talking about the informed consents, making sure that people do know what this journey is in front of them. How do people cope with illness? Complications will arise. There will be difficulties. Some, people might have to stay longer in the hospital. Do they have those resources inside of them and outside of them to support them? What is their social support? It's really hard to impossible to do this on their own. At Stanford, we do require, two caregivers full time, primary and secondary as a backup for at least 3 months after transplant. And social history is going to look at all those components and tying them all together. So in concordance with this, again, the most recent consensus document, right, that came out from the International Society of Heart and Lung Transplantation listed this as absolute psychosocial contraindications to lung transplant listing. Lack of patient willingness or inability to accept transplant, right? This should be patient-driven. This should be what they desire, and they should be able to consent. Progressive cognitive impairment, right? For example, as a progressive major neurocognitive disorder, this is also an absolute contraindication. If somebody has evolving dementia, they will be further hurt by the surgery. They likely will be delirious and will be further cognitively impaired. They likely will not be able to take care of themselves or benefit from transplant. Repeated episodes of non-adherence without evidence of improvement. No, for pediatric patients, this is not an absolute contraindication. And again, this is not surprising, right? We know in people with CF, right, as we know them lifelong, we have more history in that. We expect, right, we won't suspect that developmentally there will be times when our patients are not going to be able to adhere. It almost will be developmentally appropriate. But, now, right, having grown up, having, gone through life, are people able to take care of themselves and demonstrate that they will be able to take care of themselves going forward after transplant. Another absolute contraindication psychosocially is active substance use, as I mentioned. And there are many more actually absolute medical contraindications, right? So, but I only focus here on psychosocial ones. And the next slide demonstrates not so much the absolute contraindications, but now we're looking at the high risk factor, right? This is also something that we'll look at. And depending on how risky they are, we might put things on pause or we might just note this, right? But again, psychiatric history, unreliable support, caregiver plan, as we discussed, and lack of understanding or desire for transplant. Multiple studies have looked into these different unique factors, but I just wanted to highlight one, for example, depression. A meta-analysis of 27 papers, and again, this was done by Dr. Du and multiple other colleagues. Transplant papers included heart, liver, kidney, lung, pancreas, and mix, demonstrated that depression pre-transplant and post-transplant is a significant risk factor for worsening mortality and graft loss, right, after the transplant. And multiple other papers also have demonstrated this. And this is not surprising. We know this is true in CF, we know this is true in cardiac disease, right? That depression, untreated depression, is a risk factor. Some other papers also have noted that if depression is treated, the risk is actually the same as untreated depression. So it really puts on, it really even proper advocates that, right, the psychosocial evaluation can help our patients, right? We really can screen for those modifiable factors and address them so that they do not actually inhibit our patients from good outcomes. So the goals for the psychosocial assessment of the candidates includes identifying patients' level of neuropsychiatric and cognitive functioning, identifying the social support network, right, how available they are and how functional they are. We want to increase fairness and equity, right? These are the tools such as CyPAD are created, right? So it's not that one center does one thing and another center does another thing. We really do want to standardize the psychosocial assessment across the country, right? So everybody truly does get evaluated the same way, so we can compare that. And we want to most importantly implement appropriate treatments that reduce harm and mitigate risk and optimize graft survival and patients' quality of life and benefit from this big surgery, big intervention. In terms of the how it's actually being done in real life, right? Sometimes centers still might use their own interview they have developed, but many centers do rely on some sort of structured tool. Before CyPAD, there are also other tools that have been developed, PAC, PLS, TERS, and then the CyPAD was the one that was developed most recently, but even that was 10, 12 years ago. But I kind of wanted to, for you to see that there are definitely other tools that programs do use. And if it's not CyPAD, but PACT actually is the one that programs use probably second most frequently after the CyPAD. These are some kind of, again, the domains that the CyPAD includes, and really just, again, highlights what we already discussed: patient's readiness level, illness management, social support, psychological stability, and psychopathology, and then substance use and dependence behaviors. These are some of the earliest studies on the CyPAD. A study where almost 200 patients were evaluated. They included lung transplant patients as well. And they were kind of, the higher the CyPAD is, the higher is the psychosocial risk. And then 1 year outcomes were determined in the study. And at this point, organ failure or mortality of the patient was not correlated. And it's very possible that actually this was not long enough, but right, because the mortality was pretty low. But some other factors were already definitely being demonstrated 1 year out after the transplant. That high psychosocial risk or high CyPAD score did predict more organ rejection, more medical hospitalization, more infections, and actually, increased risk for any adverse medical outcome, as well as adverse psychosocial outcomes as well. Other studies have been done on CyPAD as well. I just wanted to highlight some of the more recent studies that have been done on lung transplant patients. The smaller 45 lung transplant recipient CyPAD study did note that one high CyPAD score 1 year post-transplant was associated with worse 6-minute walk test, more readmission, and also more mental service utilization. This other study where they assessed 914 patients, out of which 152 were declined, indicated that patients who were declined were more likely to have a higher CIPAT score, this is what the tool is created to do, so that is not surprising. I would be surprised if it was otherwise. But interestingly, once listed for lung transplant, a higher CIPAT score actually was not associated with waitlist mortality or reduced survival. So maybe also what this is capturing is that if we identify those psychosocial risks earlier, right, and we're able to engage our systems, our social workers, psychologists, psychiatrists, the rest of the team, can actually mitigate the risk. But I want to now switch to the inequities, kind of in waitlisting and outcomes. We do know that this is happening. We know that there's been inequities in our medical system, and our, Black patients, and our, Latinx, Hispanic patients do not see, right, often, unfortunately, the same benefits. And in this study, which is really alarming, published in 2023, now we're talking about liver transplant. Over 2,000 candidates were evaluated for liver transplant, and then were followed for up to 8 years. And what they found, while there's no significant association between race, ethnicity, and overall waitlisting or not waitlisting due to the medical reasons, unfortunately, compared with the white race, Black race, and Hispanic or Latinx ethnicity were associated with not waitlisting for psychosocial reasons, right? So somebody with the same psychosocial risk, their race, unfortunately, and tragically predicted whether or not they would be listed. And we do know, of course, right, that the race is a social construct, it's not a biological construct. So potentially, right, this is really picking up on other, you can say, kind of psychosocial, maybe comorbidities. But interestingly, after adjusting for social demographic variables, the relation persisted and maybe even strengthened, right, in the Black and Hispanic Latinx populations as compared to the white group. And unfortunately, what this is picking up on is probably the implicit kind of, right, the structural racism or the implicit bias of police providers obviously must have, and has been shown in multiple other studies, that, I do believe, I'm a psychiatrist, I believe that, we go into the profession to help people, right? But we've been raised, we've been exposed to what we've been exposed to, right? We have our own backgrounds and histories. And unless we truly actively reevaluate them and be honest with them, and reevaluate, right, our implicit biases, they're not going to go away. So this is a very important and sad study, but I think hopefully we can use this to help ourselves, first of all, and help our patients. This other study, and I'm sorry for the busy, slide, looks at the transplant outcomes in social distress communities. And they kind of divided, patient populations according to the Distress Communities Index, right? So kind of where they live, as it tracks by also education level, poverty, unemployment, housing vacancies, median income, and such. And patients were stratified into high and low distress groups. And what they found that the high distress level groups, kind of belonging to this group, was independently associated with increased risk of 5-year mortality, right? So again, this, the socioeconomic status, right, and kind of even this more, fanciest measures do show that, we have that our distressed patients, right, our minoritized patients do not do as well. So what does it mean for us, right? I mean, I still, the fact remains, true that if patients don't have understanding, if they don't have the right support system, right, if they don't adhere, they don't do as well. And at the same time, we need to be recognizing that this concept of this domains, right, there are multiple layers to that, right, that they're not just intrinsic belonging to the patient. Understanding of illness and transplantation, for example, is mediated not only by patients, let's say, desire for learning, right, but also the access to education, the socioeconomic facts, the distrust, often completely understandable, of the medical system, right? We know that our Black patients have good reasons to distrust the medical system that has mistreated them terribly, right? And, for example, we do know that Black patients have been referred to kidney transplant later as compared to white patients. And also they might choose kidney transplant less often as compared to dialysis, again, based on the medical history, right? So there's larger factors that we really need to be mindful of. Adherence, right? Adherence is also not a dimensional construct. Not only it depends on, let's say, personal factors, but also, does the patient have transportation to get to the pharmacy to pick up the medication? Do they have the insurance, right? So there are multiple systemic factors and other factors that we need to look at. Social support can be influenced by the socioeconomic factors. Does somebody not have social support because of their personality disorder and they're not able to form those relationships that they can benefit from? And of course, even that, right? There's a reason why somebody has a personality disorder, often it's linked to history of trauma, or are they part of the family where everybody has to work, right, to maintain, right, food on the table and insurance, right? But those are different situations. At the same time, mental health and substance use disorders, right, can be mediated and worsened by intergenerational trauma, right, and then access to care. So we really need to recognize that many things that we evaluate for, right, the multiple ingredients that go into kind of that final score and where patients are. This was a great paper by Ariola and colleagues, Race, Racism, and Access to Renal Transplantation Among African Americans. And they proposed this social ecological framework that looks at the following levels of influence, right? When we kind of think about our patients in the system as we evaluate them. There are interpersonal factors, right, within the person, interpersonal, right, between people, institutional, community, and public policy, right? And for example, racism, right, can be really embedded in all of those levels, right? There might be sort of even internalized racism, right, or beliefs or distrust, personal mediated racism, right, because we talked about this kind of this bias that providers carry within, and obviously multiple examples and layers of structural or institutionalized racism that is important for us to realize and appreciate. So who's responsible? I think at the end of the day, again, we don't want to harm our patients, right? And if our patients, when they come to us, they're not ready psychosocially, we can't harm them, right? Who's offering them intervention that they're not able to benefit from. And I think often psychosocial evaluation kind of picks up, right, on this time, right, on this particular time and place. But what it captures is, right, these inequities that have been in making days, months, years, decades, and sometimes in of course centuries prior to that. But it is our responsibility now to stop and think and really kind of take a bigger look and think about how can we, as a transplant program, as a CF program, as a hospital, and of course a society, right, support our minoritized and right and other patients who have not been treated equitably. I do want to say that I think in CF our patients actually do potentially have more support. I'm glad to often when my patients, lung transplant patients suffer, right, struggle financially, resource wise, mental health wise, I do find that it's actually much easier to find supports for people with CF. Right, the amazing organizations, of course, CF Foundation, but then there's also CFRI, right, locally in the area, Living Breath Foundation. I'm so happy being in the area to rely on this other additional community supports. And I hope we can do this for more and more of our patients going into the future. Thank you so much for having me here. And any questions, I have my email here. So definitely, happy to help and answer any of your questions.
So I did put in the chat her email as well, and she graciously will answer questions whenever you have them. And so you could see in the question and answer part her email if that passed by too quickly. And then there are a few questions there that perhaps other panel members or people in the audience want to discuss that we will bring up in the questions and answer section. Next, we have Siri Vaith, a social worker and the executive director of the Cystic Fibrosis Research Institute, CFRI, a nonprofit organization which funds cystic fibrosis research in medical and academic institutions nationwide, provides educational and psychosocial support services, and advocates on behalf of the CF community. Her involvement with CFRI began in 1995 after her daughter's diagnosis with cystic fibrosis. She currently serves on several coalitions to advance legislation and policies to improve the lives of those with cystic fibrosis and rare diseases.
Good morning, everyone. How are you? Are we awake? Say it with fervor, just so I know you're with me. And as a Californian, we all know, what time is it? It's about 5 a.m. So really, thank you all for being here. I'm just like, my heart is full to see how many people are here. This is just says so much about our community and desire to really improve disparities in our CF care. So let me make sure I know how to advance. There we go. I really have no disclosures related to this presentation, but I did want to mention that our Faces of CF Diversity and Inclusion program does receive grant funding from Vertex, Gilead, and Viatris. So before I dive into anything, I do really want to recognize Dr. Jennifer Taylor-Kauser, Dr. Megan McGarry, and Dr. Susanna McCauley for their work to advance equity and inclusion in our CF community. And I'm really grateful to the three of them for sharing a lot of the slides or parts of the slides that I'm about to present to you here. So we'll start with some historic level setting, and I'm sure many of you know this, but again, repetition is good so that we fully internalize the messages. But when you read about CF, you do the online Google search, it is unbelievable how often the words white and Caucasian pop up as a description of the disease. And we all know this in the room, that is not true of our community. But again, it's a message that's been ingrained from literally probably the first biology book in high school, where it had a description of genetic diseases and CF was the example. Or in medical books where, the picture of the person with CF is going to be blonde and have blue eyes. So here we can see the fabulous Dr. Dorothy Anderson, who, as many of you know, wanted to be a surgeon, but at that time women were not allowed to be surgeons, so she became a pathologist. And through autopsies discovered the disease pattern she called cystic fibrosis of the pancreas. And notably, the first cases that she used to diagnose this it was a really diverse group of children. And you can see from the first published article, the quote, the racial and geographic distribution was wide. And again, Jen Taylor-Kauser is the one who really has brought this document back to life for all of us. So through the years, we've also learned, of course, there are many mutations of the CFTR gene. And with improved genetic testing, we now know it's over 2,000 mutations, over 700 of which are disease-causing. And Delta F508, as we all know, is the most common, especially among people of European descent. And people of color, there we are. We're back. I didn't touch the computer, I promise. People of color are far more likely to have less common or rare mutations. And while CF is included in every state's newborn screening panel, and for all the work I do in the rare disease community, we are the envy of so many rare diseases that we are on the panel in every state. And it has really helped. The cases of CF detected through newborn screening has nearly doubled over the past about 17 years. But as many of you know, there is no consistency between state panels, and there's really not that much federal oversight to determine that. So if you look at this slide here, which complements of Dr. McCauley, you can see the range of variants that states are testing for. And if you look at that one white state there, which means they're testing for one variant, that's Mississippi. And it is no surprise that it's mainly people of European descent who are diagnosed with CF in Mississippi because they're only testing for Delta 508. And so when you have this, you have lower diagnosis, and really this whole cycle of disparities in care begins. Okay, we all know how Trikafta has transformed the lives of many, and that includes my daughter, whose life really has turned around because of this. There are all the countless success stories off the transplant list, off oxygen, working, marrying, having babies. But for those people who are ineligible for Trikafta, things really have not changed much. It's really it's the year 2000 still in terms of what options are available. And many friends who are ineligible to use modulators have described it. I'm so happy for all my friends with CF who are on them, but it is literally like staring through a window and there's this happy party going on in this very warm, cozy house. And I'm out here in the cold watching and waiting. So we need to change this. The people who are out in the cold are more often than not people of color. So Jen Taylor-Kauser put this slide together a couple years ago, but it really shows well the disparities in therapeutic options. And the 10% we all refer to, it's the final 10% we need to find therapies for. But within this 10% are the rare within rare community members who, due to their mutations, are ineligible. And if you look at the numbers there, 24%, so 1 out of 4 Latinos are ineligible for modulators, as are 30% of Black community members. So we really have to think about it when we say the 10%, think who is within that group. So the underdiagnosis of CF in underrepresented communities and a historic lack of inclusion in clinical trials by people of color have exacerbated what was already a painful reality. And even before the development of modulators, outcomes have been consistently worse for people of color. And there's some studies there. The study Sawicki and Jane et al. It's just one of several that show even when you control for education and adherence, number of clinic visits, all that Latinos have lower lung function, earlier mortality, just consistently worse outcomes. And I couldn't resist, I just had to throw in this photo because he is so young, and you can see he's sitting next to his sister. His sister has already had a lung transplant. And about 3 years after we took this photo, he himself had a transplant. It just really represented how dire the situation is. And then with all thanks to my friend Kimberly Morris, I have the slide from CHLA, Children's Hospital Los Angeles. And I just want to say immediately on your behalf, Kim did not cherry pick these patients. She didn't go in to try and make a point about this. This literally was a snapshot of who was inpatient in 1 week at CHLA. And, you know, we all talk about the remarkable lack of hospitalizations for CF since Trikafta started. And so here is really the clearest picture of who is still being hospitalized. And you can also see here, and I hope from the back of the room you can see this, people's Trikafta status, whether they're eligible or not. And you can see the majority of those kids are not eligible. Before I move on, though, I really want to give kudos and a shout out to CHLA, because look at the bottom line, which is about who's participating in research. And that shows such intentionality about recruitment and asking. If you don't ask, the answer is always no. Clearly, CHLA is ahead of the curve in terms of clinical trial recruitment. So, and of course, I just want to take a moment to recognize the fact that access to therapies is an issue for the global CF community. And clearly, we could spend the entire day, or maybe the entire spectrum of NACFC, talking about the issue of drug pricing and access, and especially when it comes to modulators. But it's also really important for us to remember across the globe that before we can even talk about access to modulators, we need to think about a whole structure to have some kind of infrastructure to even be able to think about them. And just a little anecdote, I don't know if there's anybody from Stanford team in the room here, but they had a wonderful pilot this year where they brought up select people from Peru to form a CF care teams, to come to Stanford and see this is how it works, these are the different roles. Pull people together, and they were very excited. They're like, we're going to do this, and we can't wait to have modulators. And I had the good fortune of going and filming a podcast with them. But what became clear, they have newborn screening in 2 of the hospitals in the entire country. They do not have an existing CF team, or did not at that point. And to even do the genotyping to decide if a person would be eligible, they're still sending their samples off to Uruguay because they don't have the capacity in the country. So it's just a reminder to all of us as a global CF community how far we have come, how privileged we are here in the United States, but also sort of a global responsibility to get us to the next phase. So I was thrilled to hear Dr. Scher, who I hold in the highest esteem, talking about unconscious bias and implicit bias when it comes to making decisions about transplant. And, you know, just as a reminder to everybody, it's a prejudice or a stereotype that you may hold, and you're not even aware that you hold it. Also referred to as implicit bias, it can be about race, gender identity, sexual orientation, economic class, physical abilities, or even physical traits. And I know by virtue of being in this session. You're committed to providing optimal care and eliminating bias in the hospital and the clinic setting. But, the key thing to notice about implicit and unconscious bias is that we all have them. And it isn't a good or bad or shame and blame issue. It is just recognizing that from the moment we have our first conscious thoughts as little babies and toddlers, we are inundated with messages about social grouping. And depending on where you are and what you're seeing, these become internalized, and they may not even be on par with your conscious thoughts and values. But it's something that we need to recognize. So again, not good or bad. It's a recognition that you have it. Until you recognize it, there's no working to overcome that. So there have been many, many studies on the impact of unconscious bias in the healthcare setting, and these consistently demonstrate that implicit bias negatively impact the level of care that's provided to racial and ethnic minorities across disciplines and care. And this is most notable about care provided to Black patients. So as an example, Black patients are prescribed less pain medication, receive less aggressive heart attack treatments, receive fewer cardiovascular referrals, achieve poorer reproductive outcomes, experience, and this is key, less patient-centered communication. And of course, this bias also goes across groups, class, age, weight, whether a person's living with IV, whether they inject IV drugs, whether they have a disability, whether they're part of the LGBTQ plus community. And all of this translates, as Dr. Scher said, to that issue of adherence. It's just so easy to be black and white. They're adherent, that's great. They're not being a good patient. And yet there's so many layers that lead to lack of adherence, lack of clinic visits, because you don't want to interact with somebody who's making you feel lesser than or treating you that way. So how best to reach and serve our patients? And I thank you, Kim, for this slide. The key is intentionality. The intentional focus would be applied to every facet of the CF ecosystem. And I had a friend who, years ago, he was one of the first people when they started school busing, and he was bused from Harlem to schools that were predominantly white. And he ended up becoming a diversity trainer. And the one thing he said to me, and he's passed away since then, is every time you go in a room, Siri, look around and say, who's in the room? And then ask yourself, who's not in the room? And you use that as your point of intentionality to move forward. And so I think that's something we all need to remember and internalize and translate that to when we're recruiting for clinical trials, when we're recruiting for new team members, that we have that intentionality and that we work from a patient-focused framework in which we listen to and we're open to hearing about the lived experiences of those with CF. So I'm going to have a few slides here that have voices from our community. I do want to know from the people in the back, can you read those words? Yes, thumbs up? Thumbs up, okay, great. Because I won't, we all read at different speeds. I'll just give you a few moments to read the message. So Ray was raised in a predominantly white community and treated in a basically white hospital environment, and her symptoms were missed for years. And even after she was diagnosed, finally at the age of 26, she was told that because she was Black and because one of her mutations was very rare, that it wasn't really even clear if she had CF or if they should call it CF. And so as a result, she was not given any home care. She didn't have any of the standards of care for the home regimen for treatment. And she only had interventions when she would get really sick and was back in the hospital again. And has had, of course, a resulting decrease in lung function because of that. Mao is part of the Hmong community. She has 13 siblings, and of the 14 kids, 5 were diagnosed with CF. She didn't know any other East Asian people with CF other than her siblings for most of her life and felt extremely isolated. And she said she often feels gaslighted when she seeks medical care, not from her CF team now, but like, for example, this interaction with the emergency department. that medical provider who kept insisting she had asthma, as if she would not know her own disease in her own body. So that care person clearly deeply internalized that CF is a disease of white people. Everett recognizes he was helping, he is still helping raise awareness and educate team members and care team providers of the diversity of the CF community, but he notes it was often frustrating dealing with the probably unintentional, but still insensitive comments from care team members. Hema notes that even care team members, primarily care team members, kept telling her, this is just so rare. It's really a disease of white people, which completely undermined her confidence in any test result. And so she had him tested 3 times. But she does believe it was this biased misperception that kept her son from being diagnosed for 14 years, during which he suffered, obviously not benefiting from needed CF therapies, but also mental health issues. I mean, he has told me just the worst stories about this cough that he had and how he was shamed about it for all these years. My conversations with Jalen and Deanna were incredibly moving and really incredibly disturbing. Deanna told me that because her husband is very dark-skinned, when Jalen was diagnosed, a care team member actually asked her if she was sure her husband was Jalen's father. This truly happens. And she said, how do you develop a relationship of trust or partnership with the care team after something like that? And Jeannie shared that during her medical training, she treated people with CF and started thinking, they have the exact same symptoms I have. So she says that while in training, she was regularly gaslighted by other healthcare providers, and supervisors who dismissively said she was just identifying with the disease in front of her. And now her lung damage is irreversible. Her beloved sister has died, and one can only ask whether she would still be alive if she had been diagnosed earlier. So social workers, mental health providers in this CF Center do play, of course, a huge role to advance patient-centric practices that empower BIPOC patients and their families. And every year, CFRI conducts a survey of CF social workers to assess what resources they believe are missing, and in particular for their BIPOC patients, but in particular for those that do not speak English. And I just want to note 48 respondents. Thanks to those of you, if you did answer the survey, who were in the room, and please help us this fall when it comes to through the CF listserv, please respond. That would be very helpful. There's so many things I could talk about from that survey, but the key thing is the last item, that 79% of respondents have needed to employ advocacy techniques for CF patients and caregivers of racial and ethnic minorities towards other members of staff, being the ally, being the advocate. And when asked what techniques were used, they included attending patient appointments, speaking up for one's patients, coordinating care between specialists, affirming patient rights, and educating other providers. So a key thing we can all do is seek out resources not only for our patients and our families, but for ourselves. I love that concentric circle that Dr. Scher showed, because it really starts with each one of us, and then it begins to radiate out until it is about policy and a bigger systemic response. So there are many resources available. This is just a little snippet of things for CFRI that you can offer. With lots of podcasts and printed materials in English and Spanish and some in Hindi. Our CF in the classroom, Fibrosis en la clase, we send thousands of copies of that out. And now I just want to announce, hot off the press to the right, we have a teen guide that was developed by members of our Diversity and Inclusion Advisory Committee. And we just released it, and it's available in English and Spanish. We'll be able to send it to anybody who wants it. And I know I'm running out of time. I'm sorry. The other thing, I just want to go back for 1 second. In terms of mental health, we actually cover 6 sessions of therapy for people. And I just really want to remind people, we do have people who are utilizing this because they have found a therapist who speaks Spanish or their native language. So please keep your minds open when you're thinking of your patients to refer them to that. We also do have a Spanish language support group every month. And then, of course, there are other wonderful projects out there. I'm looking at Laura Bonnell from the Bonnell Foundation right now. Many resources that I encourage you to tap into, again, for yourself and for your patients and families. There is just such a wonderful groundswell of organizations and CF centers, and the CFF now has many, many resources as well. It's about just diving in. And so now there's more examples of the research and real-world patient-centric projects that are taking place. And there's just so much room for hope as efforts grow to address historical disparities and to improve CF care for all. So we will have questions at the end, but I thank you so much for your attention this early morning and your intentionality.
Thank you so much, Siri. Really enjoyed hearing from you. Okay, so our next speaker is Jessica Balcom. Jessica is a certified genetic counselor and assistant professor of laboratory medicine and pathology in the College of Medicine at Mayo Clinic, within the CF care working from newborns through adulthood. Or working with newborns through adulthood. Jessica manages a team of 25 laboratory genetic counselors, genetic counseling assistants, and variant scientists at Mayo. Jessica is a current member and past chair of the CF Special Interest Group of the National Society of Genetic Counselors.
Thank you so much for the kind introduction and the opportunity to contribute to this session. I've learned so much already from the first 2 presentations, so really exciting to be part of this. No disclosures. So for my portion of the session, my objectives are for you to come away with resources and information to identify ethical dilemmas that arise in the context of genetic testing, and be able to apply ethical theory framework to evaluate and manage this type of ethical dilemmas in your role as part of the CF care team. To start with, I wanted to introduce a little bit about the primary ethical theory frameworks that underpin genetic counseling practice. So as a profession that integrates medicine and psychology, not surprisingly, our code of ethics is informed by 2 primary ethical theory frameworks, both biomedical ethics, which I imagine is familiar to most or all of us, as well as the ethics of care principles. So from a biomedical ethics perspective, typically the primary considerations that we are looking at when we approach an ethical dilemma include maintaining or optimizing beneficence, working in the patient's best interest, minimizing harm, non-maleficence, promoting patient autonomy, and striving for justice and equity across our patient populations. From an ethics of care perspective, this theoretical framework really centers the patient-client relationship, the provider-patient or provider-client relationship. And so in this context, provider could be any member of the healthcare team, And the guiding principles here really prioritize the consideration of how any given decision or course of action will strengthen or potentially disrupt that core relationship. So with these two principles in mind, or two sets of principles in mind, I pulled out an excerpt from our professional code of ethics for the Genetic Counselor Society that really illustrates, I think, how these are interwoven. The counselor-client relationship is based on values of care and respect for the client's autonomy, individuality, welfare, and freedom. The counselor's primary concern is the interests of their clients. So very applicable, of course, to any role within the healthcare team. There are a number of ethical dilemmas that can arise in the context of genetic testing or genetic counseling. It's really, I think, throughout the history of genetic counseling as a profession is really interconnected with ethical challenges that arise whenever we approach genetic information. So today I'd like to take time to talk about a few examples that illustrate the types of issues that we encounter in genetic testing, including for conditions like cystic fibrosis. So this includes issues of equity and access to genetic testing, which complements some of what Siri already shared with us this morning. Test selection and appropriateness of testing, informed consent, managing incidental, unexpected, or complex test results, what happens when the interpretation of a result changes over time and how we manage that. And finally, addressing the aspect of genetics that introduces a lot of complexity, which is that a genetic diagnosis is, of course, impactful for the patient, but also has implications for their family. So there are issues and considerations that arise with how patients are recommended to share that information with their relatives in the context of their own unique family dynamics. So this is really complementary to what Siri shared about some of the history of how genetic testing was developed historically for cystic fibrosis and different approaches that can be taken for genetic testing and how those relate to ethical considerations. So historically, on the left, CF testing was focused on targeted mutations in the gene that were, quote unquote, known to be disease causing based on the study of populations in which CF was common, which was primarily populations of white European ancestry. So the benefit of that type of testing is that you're looking for results for which you know what the clinical significance is. So if you get a positive, the result is very clear, it's clinically actionable, it's fairly straightforward for a provider to say, we tested for the ACMG 23 recommended mutations, you tested positive for 2 copies of F508del, that's consistent with a CF diagnosis. The problem, of course, is that this approach is biased toward what mutations are common in well-studied populations, and these type of targeted panels have lower sensitivity in other populations that may have a different spectrum of mutations. So taking this approach on a population level or individually in terms of what's offered can contribute to healthcare disparities. By contrast, more and more in the current state, the recommended approach for testing is to perform full gene sequencing. So rather than selecting for specific known mutations, interrogating the entire gene, and thereby mitigating some of that population-dependent test sensitivity variance. So this approach can improve equity in the testing approach, but it does open up a broader range of possible results. So when you're not targeting the testing and you're sequencing the gene, results can come back as either one of those known mutations or something that is novel or less well understood. So we're improving, I guess, one aspect of the equity of the testing, but it does open up other potential ethical challenges in terms of the complexity of the test results and how you approach informed consent and counseling for patients in that type of testing context. Next domain of issues that arise in the context of genetic testing relates to test selection and appropriateness of testing. So by this, I mean that ethical dilemmas can arise when consideration for genetic testing does not necessarily align with what the best practice guidelines are or standard testing protocols are. And the example that I want to share here that illustrates this domain of ethical challenges are requests for prenatal or preimplantation genetic testing for couples who are carriers and at risk of having a child with CF. So this decision in any context is significant for a couple and the healthcare team to work through and weigh the pros and cons. But the complexity is increased even further when the parental mutations include one or more variants of varying or uncertain clinical consequence, and really kind of ups the weight of that question of whether the testing is appropriate and indicated and how to counsel couples through that consideration. So on the right-hand side, I have a visual of what I mean by parent genotypes being a little bit more complex. So we're all familiar with the autosomal recessive inheritance 1 in 4 for cystic fibrosis. And so that's shown here where parents are both carriers for a mutant allele and would have a 1 in 4 chance with every pregnancy that the child would inherit both of those mutations and be at risk or affected. So when that mutation is something like F508del, it's relatively straightforward. We'd expect that if the child inherited 2 copies of F508del, they would be diagnosed with cystic fibrosis. We have a good idea of what that prognosis and natural history is, and couple can be counseled accordingly and consider. And that's a very, I think, standard indication for offering prenatal testing or considering preimplantation genetic testing. But if one or both of these parents is a carrier for something that is not as clear-cut, so for example, the D1152H variant is one that's classified as varying clinical consequence, which means that we do know a lot about this variant, enough to know that some people who have a copy of that mutation will develop symptoms of cystic fibrosis, some will not. And so in this case, working through that with a couple to consider prenatal testing, it becomes significantly more complicated when you can't anticipate, even for the child who inherits both of those mutations or for the pregnancy, what the clinical outcomes will be for that child. So this raises considerations for how to support patient autonomy and ability to access testing that is medically available. Weighing that with how much influence the healthcare team or the performing laboratory should have in potentially gatekeeping that testing or weighing the appropriateness based on, again, the clinical significance of the variants or what the couple is intending to use that information for. It also complicates the informed consent process when we're not able to really anticipate definitively what the prognosis for that outcome will be. And we also know, I think, across the board with CF that we're constantly making improvements to treatment. So even in the context of a clear-cut genotype, what that clinical outcome will look like is likely to be significantly different over the years. So once we've performed testing, one of the domains of ethical challenge that arises frequently, I would say maybe less common in the context of cystic fibrosis, where we're doing very specific targeted testing for one gene, but in genetics as a whole, oftentimes what we're encountering are the potential for incidental or unexpected genetic test findings. So you've gone through a process of informed consent with the patient for what testing they're going to undergo, what the possible results are, and then for a variety of reasons, the result comes back differently. There's some nuance between the definition for incidental finding versus unexpected finding in the context of genetic testing. So typically, an incidental finding is something that arises that's outside of the stated scope of the test or primary indication for testing. So more likely to be something that the patient would not have been counseled for as part of informed consent or potentially would not be anticipated. Unexpected test finding often used to describe results that are within the scope of the testing being performed, but might be incongruent with the clinical indication for the testing. So a couple examples to highlight, and again, this is especially the case example for incidental finding, does not come up often, but it is something that can occur anytime we approach genetic testing, and so it's worth healthcare providers keeping in mind and being cognizant of talking through the potential for a range of results with genetic testing. So an example of an incidental finding would be we have a new diagnosis in a child. Parents undergo carrier testing. We're expecting both parents to come back as carriers for one of the child's mutations, and instead, dad's result is negative. And certainly in that case, there's other potential explanations, but that's going to open the door as to whether there's potentially misattributed paternity in the family and a pretty challenging communication scenario to go into. Versus unexpected test finding. Again, this is one that is, I think, coming up more recently as the scope of genetic testing and the ways in which it's used is quite broad in the medical community. So, for example, patients may undergo genetic testing for familial cancer risk. There's a whole spectrum of genes that can predispose to increased risk for cancer, and these panels have become increasingly broad in terms of their coverage, to the point that in the current state, some of these panels even include CFTR, among other more well-known or well-established cancer predisposition genes. And so it's possible, and this is something I think that we're seeing more in genetics, is that patients come in getting testing for one reason and then come back with indication of a different risk entirely. So you may have a patient who is undergoing risk for cancer screening, but the result actually comes back with 2 CFTR gene variants, which may be those varying clinical consequence, things that wouldn't necessarily be clinically recognized as CF, but then need to be managed accordingly. Generally speaking, in any scenario of incidental or unexpected findings, the primary ethical consideration is whether or not to disclose. That really varies. So in the case of a patient who had a panel that included CF and they have CF variants, that's obviously going to be reported back and it's going to be managed. It's more of a, I think, quandary in the case of the incidental finding, like the negative result in dad, and how that would be handled with the family. And again, it really highlights the importance of having comprehensive informed consent prior to testing, and preparing the patient for the range of results that could possibly come back from a genetic test. Expanding on that a little bit in the context of those biomedical ethical principles, this really, I wanted to highlight that even when you are considering one principle within a given framework, there's still a number of interpretations that could reasonably be made in terms of what's the best course of action to uphold a certain ethical principle. So if we consider autonomy in the case of an incidental finding, you could reasonably, I think, conclude that upholding patient autonomy can best be done by disclosing that incidental finding or unexpected result, because patients have the right to know information that may be significant. On the other hand, an argument could be made that patients have an equal right not to know information that they didn't consent for. So when something comes up out of scope of the test, I think it's really gray as to what is the quote unquote best course of action, and what will be upholding the best ethical principles for the patient. Likewise, you can consider what will do the least harm or provide the most benefit to the patient, which is going to vary depending on what that incidental finding is, and upholding the parameters of informed consent from a justice perspective. So, of course, these issues are ones that we talk about as being dilemmas because there's not a clear-cut necessarily path forward. And really I think, best thing that providers can do for themselves is to really think through the pre-test counseling and informed consent process to minimize the surprises that come out of genetic testing. So variant reclassification, one of the inherent aspects of genetic testing is that our knowledge of the clinical significance of variants changes over time as more research is done and we have more information available. So inherently, there is the potential that a result that is reported out to a patient at one moment in time may have a different clinical interpretation in the future. And this is something that the community really struggles with, how to manage that and who has responsibility for managing that, from the spectrum of the performing laboratory to the genetic specialist provider who may have ordered the test, to the primary care team that's going to continue to follow that patient, to the patient themselves. So it's complicated. The professional guidelines that exist provide some guidance, but also I think leave a lot open to interpretation. So the American College of Medical Genetics recommends that laboratories performing testing suggest periodic inquiry by healthcare providers, so encouraging the healthcare team to follow up on any patient results that are unclear significance to see if new information is available. But it's also encouraged that the laboratory attempt to recontact that provider team if findings have differential clinical or established personal utility due to a reclassification. Recontacting should strive to be equitable, which is not always easy to achieve for a laboratory to ensure that they can contact the healthcare team that is currently caring for the patient. So I would say actual practice here is variable as to how healthcare teams discuss this with patients and how much onus they put on the patient to bring those questions back to their healthcare team. One example of this is the 5T allele, which is one of the more complex varying clinical consequence variants. The 5T can occur in multiple forms with the number of TG repeats. So one specific allele is the 5T11TG. This is a screenshot from the CFTR2 database, which again this is not highlighting an oversight or an error, but rather an evolution in our understanding of genetic variant significance. So in 2015, this variant was classified as a variant of varying clinical consequence. So somebody who tested positive for this variant as a carrier may have been counseled that they could be at risk to have a child with CF who may develop CF. Whereas in 2021, the CFTR2 group reclassified this as a variant that does not cause CF. And so that type of reinterpretation does definitely occur and introduces complexity in terms of how we manage that in a way that is optimal for patients individually and for our overall process at a population level. The last domain that I wanted to discuss is the concept of genetic diagnosis disclosure to at-risk relatives. So anytime we're considering a hereditary genetic condition, including cystic fibrosis, again, the diagnosis has obviously significant implications for the patient, but also by nature will have significance for the patient's family. So we're always, I think, managing those dual levels with genetic conditions of how do we care for this patient and support them and manage their care, and also how do we educate and support them in understanding what this means for relatives and how and when to share that. So patients oftentimes may struggle with whether to share information, how to share that information, who needs to know, who's actually at risk in the family. And the process of disclosing to relatives that they may have a risk for an inherited genetic condition can be further complicated by either a genotype that's complex. So we've covered a few examples of mutations that are not clear-cut disease causing. And anytime you have that level of complexity, it really increases the I would say, burden on the patient to be able to convey that to their relatives and try to share that information. Or by complex family dynamics. And this is where I think this really intersects with the scope of the mental health practitioner on the team. Every patient is going to come with their own personal familial context in terms of who they're close with, who's their support system, is there estrangement, is there complex family structure, and all of those, of course, are going to impact on the way that the patient thinks through that conversation. So from a genetics perspective, oftentimes doing the family history pedigree intake is our opportunity to solicit some of those details of what does this family context look like and what is it going to mean for this patient to potentially be counseled that you should share this with, your siblings, your cousins, whoever it may be. So really, the healthcare team in this context is a primary resource to help patients navigate potentially complex family dynamics and where it can be challenging for the provider to weigh our responsibility to make that recommendation to the patient that best practice is to share the information while respecting the patient's autonomy and the context in which they're operating in their family. So some general strategies to support patients with this type of family communication: always maintain a person-centered approach. So again, speaking to the elements that are significant for that patient rather than a general template for all of your patients. It's important to assess the potential patient misconceptions about inheritance and risk and make sure they understand who they do need to communicate to in their family so that they're not oversharing and burdening relatives who it's really not relevant for. And to take the time to explore those family dynamics that could potentially enhance or prohibit effective risk communication. Is there somebody in the family that would be an easier person to start with to have the conversation in a way that will be successful and then build from there? Or can somebody be the messenger in the family and continue to disseminate the information? Supporting patients by helping them to develop scripts for the conversation or even role play what that might look like. And providing resources. So from a genetics perspective, it's standard for us to provide a letter to relatives that outlines, hopefully as clearly as possible, that someone in the family has a genetic diagnosis. Here's what it means for other people. Here's how you could get testing and resources. And ideally, you can support the patient with clear and simple strategies for what needs to be communicated. So we recommend that you share this information with these relatives. And from some of the published studies, it is helpful and supports positive outcomes or successful outcomes with communication if the healthcare team can follow up with patients and continue to offer support through this process. Sorry, I'm over my time. So this I'll end with is just a general framework for approaching any type of ethical dilemma, which is, I think, on one hand, super basic, but on the other hand, a helpful framing to ensure that you're following that logical flow to define the problem, frame the problem, consider what possible solutions exist, and then take action and reflect on that. Thank you.
All right. I'm wondering if that letter could be housed on CFF or CFRI so that centers could just download a generic version and then adapt. All right. So our next speaker is Dr. Natasha Emerson, a psychologist and an assistant professor in the Division of Child and Adolescent Psychiatry at UCLA. She directs the Pediatric Psychology Consultation Liaison Service at UCLA Mattel Children's Hospital and co-directs the UCLA Pediatric Psychiatry Consultation Liaison Service at UCLA Santa Monica Medical Center. Her research in integrated psychological services cut across multiple medical complexities, and she's worked with patients with CF for 5 years and feels lucky to have learned so much from such inspiring patients.
Hi, everybody. Thanks for bearing with me as the last speaker, but I'm really excited to be here. Okay, so just as a little bit of background, and thank you so much for that lovely intro. I have no conflicts of interest to report. But I just wanted to frame some of my knowledge here, not just as a CF psychologist, but just to say that I work across many diseases at UCLA. And so I think some of what I've done is pull from my research across these patient populations. So briefly at UCLA, I have been working with with patients with CF since 2019, and we're supporting a growing adult patient program that receives patients from a variety of local pediatric centers, including UCLA, CHLA, Loma Linda, and Long Beach. So some of my colleagues already kind of went through the ethical principles. These are the American Psychological Association ethical principles, but you'll see some of those names carry across disciplines. And so we'll kind of look at what really applies here when we're thinking about lung transplant. So what do we want for our transplant patients? And I want you guys to think about this, put on the hat. I think most of us here are probably not the ones who are doing the actual pre-transplant evaluations, though some of you may be. But I want you to think about your dual role here as people who are in an integrated medical team, as well as people who have responsibility and fidelity to your patients. So first and foremost, I think we want to make our patients to make informed decisions, right? I think it's very common for patients after any sort of solid organ transplant to say, I wish I'd paid attention a little bit more. I wish I knew some of these kind of like side effects that I didn't expect. And this is obviously very difficult in the context of providing consent for a life-saving treatment, because I think many of our patients are just thinking about this as this is what I need in order to stay alive, to be here for my family. And so a lot of the details kind of fade out. We also want to make sure that our patients are taking care of this organ, right? So in contrast to some of the other settings that I'm in, for example, in oncology, when people are receiving bone marrow transplant, most of those are sibling matched or even autologous from the patient's own stem cell. And so in those settings, we're not taking a transplant from a better candidate and giving it to somebody else. It's really, do you want to save this kid's life or not? Whereas with lungs, hearts, all of our other solid organ transplants, we want to make sure that we're giving it to the best candidate because we know that there's somebody else further down the line who may do better with it. So briefly, this kind of breaks down along two of these categories. And in terms of team members in an integrated team settings, fidelity and responsibility comes in. So working with people at the end of life, one of my other gigs is supporting young adults with advanced cancer at UCLA, particularly sarcomas, which have a really terrible prognosis. And so I've thought about this clinically in a lot of ways of helping patients not only have good quality of lives, but if we're thinking about good lives, we also want to be thinking about good deaths, right? And what are the choices that patients would make if they had a better understanding of their prognosis and how it directly impacts quality of life? What does this person value in terms of their life outside of the hospital? Are they people who are kind of homebound and would be happy to be in a hospital room with their best friend who's their mom because all they do is watch bad reality TV and so it doesn't matter where they are? Or are they avid travelers who have this huge bucket list and who would actually be really harmed by futile interventional treatments at the end of life? We also want to think about the other players at stake, right? So we're not just thinking about these individuals in the vacuum, but what is their family like? Who will be grieving them if they're not here? How do we support those family members who may have differences in terms of decisions and treatment at the end of life? And then, of course, working in integrated settings, as mental health providers, we're kind of tasked with helping, first and foremost, I think most of our team members understand their patients better, right? Whether you're working in an inpatient setting or outpatient settings, as psychosocial providers, as mental health providers, we're trying to give our doctors, our nurses, our respiratory therapists, kind of a broader view of how patients function outside of being patients. and what kind of psychosocial factors influence their day-to-day decisions. So here we come to our case example, and I think that I want you to kind of think about what you would do in this situation. So I've kind of fictionalized this a little bit, but this is a real patient. So we'll talk about Sarah, who's 32, and she lives with her parents, and she actually transferred to UCLA a little bit belatedly because she was very, very attached to her pediatric center, which I think is true for a lot of our kiddos. So she lives with her parents, who are very, very supportive, and she has pretty advanced lung disease. So she's not working, and she's been really too sick to function in most occupational or educational settings. When I first meet her, she describes to our team that she has an ex-boyfriend who's in jail under kind of mysterious circumstances, but she believes he was kind of wrongfully convicted. And so a lot of her time is spending advocating for him, writing to him. But across the course of her relationship with our team at UCLA, she actually ends up leaving this person and getting into a new relationship. At this stage of the game, she's actually in the early evaluation stages of transplant. So she's kind of told, you don't need a transplant right now, but in about 1.5 years, 2 years, we foresee that you will. So why don't we actually go through and do some of these jumping through hoops of the psychosocial evaluation, of the medical evaluation, so that when you need a transplant, you're good to go. So she asks to meet with me as a psychologist in our center, and she says that she has new anxiety. So some of the things that kind of come across are that this patient has never had any mental health needs particularly. And unlike our team social workers, who are actually in the front here, the psychologists in our center don't necessarily meet with every patient. So it's kind of an as-needed basis. If somebody has a mental health history or an adherence history, either the team might suggest it or the patient might just say, hey, I'm going through a rough time. Can I touch base with your psychologist? So in this context, she asked to meet with me, and she describes having these kind of new onset panic attacks. And so I'm kind of reviewing her history, trying to figure out in her pediatric center, has she had a baseline anxiety? Does she have medical trauma, right? We have so many patients who've had these really traumatic hospitalizations and experiences. She kind of denies everything. And then she says, well, there is a new stressor. And she's kind of having difficulty telling me, and she's kind of dancing around it. So I kind of proceed with just kind of warming her up, trying to figure out more. And she mentions that her boyfriend, who's recently moved in with her and her parents, has unfortunately relapsed with heroin addiction. And that he was clean for many, many years. He'd also been in jail, and she is now struggling to find him treatment because he was doing really, really great, and all he needs is Suboxone, but there's insurance barriers. And so in this context, she feels incredibly torn, and it's difficult. And so I ask her, so immediately I jump into problem-solving mode, and I'm looking up these Suboxone centers so that he can get this once monthly shot and hopefully get back on track. But in the back of my mind, I'm trying to think about how this may affect her transplant candidacy. Now, she had already gone through and met with our outside adult psychiatrist. So she'd already kind of marked all those check boxes. And I am sort of stuck thinking, do I tell the team? Do I not tell the team? What are the chances of her being in a relationship? I mean, from my understanding, you don't really stay in a relationship with an IV drug user. You either start using drugs or the relationship breaks up. And so is she at risk of developing her own substance use? And of course, she's very, very scared because she's passed some of these metrics. They even kicked out her brother, who was just smoking cigarettes, out of the house just to make sure that she qualified for transplant. But here she is trying to get help for her anxiety, and I have a duty both to her and to our team. I think it's worthwhile to mention that not all transplants are created equal. So I actually checked in with our lung transplant doc and got some of these stats to reiterate that even when we're talking about lung versus solid organ transplant, our mortality rate for double lung transplant is incredibly high, despite really, really good surgeons and really great science. And so not only are we thinking about could these lungs go to somebody who's a better match, but also compared to heart, kidney, liver, chances are that patients are not going to live very, very long. Now, we have patients at UCLA who've had a lung transplant for 25 years. So I know that there's large extremes, but many of our patients have this very shortened life. And so I think that is another kind of ethical component we need to consider. So briefly, I know most of you guys will be familiar with this, but in thinking about my work with cystic fibrosis patients, I've kind of had these themes come up. I think one of the most common ones that I've seen, and this really differs based on the other disease populations that I work with, is that I think cystic fibrosis patients in general have the desire to be psychologically stable. Many of them are brought up with this feeling that they have been a burden to their families because of their medical condition. And so they have a tendency to sort of want to be this like incredible psychologically resilient person. I cannot be depressed, I cannot be anxious because I already have CF and that's enough. Also, when we're thinking about, I think both pediatric and adult care, most of these patients have really close bonds with their medical teams and they don't want to disappoint them. So for some of our adult patients, we might follow them for 25, 30 years, and our medical doctors are close to their patients. They get invited to weddings, they get invited to funerals, unfortunately, but they get to know their children, their children's names, all the latest drama. And so I think that there is this really hard to shake desire to be a good patient. And that sometimes prevents patients from help seeking. Most of them have had some medical trauma, right? Even with the best care, we know bad things happen. And I think many of them were told before Trikafta that they were going to die. And they didn't die. And so that creates, I think, some degree of invincibility. And by that, I mean that many of them, I think, many patients with chronic medical conditions over the years develop beliefs that are not necessarily always in line with current medical practices. You know, we all hear patients say, I know the dietitian tells me that I need enzymes because I have pancreatic insufficiency, but I don't need enzymes. I'm telling you, I swear, I've lived many years, I don't need enzymes, right? Or, well, I don't really like doing, nebulizer treatments. So what I do is actually do a shorter version, but trust me, it doesn't affect my PFTs, right? And the RTs in the rooms are like rolling their eyes. And then, of course, in the age of Trikafta, and I think some of my colleagues briefly alluded to this, all of a sudden, they have this new chance at a normal life. And so it's creating a lot of angst, even though it's a wonderful, wonderful problem to have. All of a sudden, they're expected to be living fruitful lives occupationally, educationally, socially, and trying to catch up to healthy peers who have gone to college, have gotten married. And so that creates a lot of distress. So all of these factors, I do believe, lead to minimizing psychological hardships and obvious and often underreporting challenges with adherence or just general psychosocial issues. Here's a patient quote. It's not an exact quote, but it summarizes it pretty well. I've been in charge of my health since I was 11. My parents thought I was old enough. And then I would go to my pediatric center and the doctors would just tell me out for doing things wrong. So I just gave up. I couldn't win and grew accustomed to telling them what they wanted to hear. How many of you in the room have heard some variation of this, right? I think a lot of room. So I really want us to think also about adherence as not a black or white function. It's a dynamic process and dynamic concept. And so this is a young adult with advanced lung disease we have in our center who's currently not even going to be referred for lung transplant. She may be adherent to some of her treatment, but she's not adherent to all of her treatment, and so she's been sort of put in the black box. I said bad box, but the reason I said black is that it was very illustrative from Sherry's presentation that this patient happens to be Black, and the patient that I'm considering that is in my case presentation is white. And so I just want you to think about that for a moment, because adherence aside, there are high psychosocial risk factors in the case presentation that I'm thinking about. There's a lot of complications with this patient who's presented here on the quote, and the one difference is their race. So that stands on its own. So I think for many of our patients who finally open up to a psychologist, who finally say, hey, wow, I mean, I know UCLA is lucky to have 2 psychologists. Many centers do not have psychologists, but for the first time, these patients are coming and they're sort of unburdening themselves of a lot of these kind of mental distress and anguish that they've had to live with and sort of minimize over the years. That's supposed to say sacred instead of scared experience. Bear with me. But so it can be a really, really liberating experience. But at the same time, working as a psychologist or social worker or psychiatrist in these integrated team settings really depends, like that relationship really depends on close communication and trust between team members. So I'm very passionate about working in multidisciplinary teams, and I want the team members to trust me. I want them to trust the patients. We want to have this close relationship. So what do you do with dueling obligations to your team and to your patients? Who comes first? So thinking back to our case example with Sarah, I want you guys to think about maybe who your allegiance goes to. And I don't think that there's a right or wrong answer, but for somebody who's already maybe passed some of these kind of screening metrics, who have kind of greenlit her to perhaps having a much longer life, how do I break the trust with the confidence that she's bestowed in me? And at the same time, make sure that I'm also protecting our center's standards and making sure that they're giving lungs to people who will take care of them. How do we encourage people to disclose non-adherence before it's too late, right? Without feeling like we're kind of dangling this carrot at the end of a stick of, well, maybe you're going to get the lungs, maybe you're not. It's really difficult, right? Most patients will just say, yes, I'm doing everything correctly, I swear. And how do we provide mental health without jeopardizing our institution's clinical metrics as a transplant center, right? I want UCLA to succeed. I'm really passionate about my institution. At the same time, I want to help this patient and I want her to know that this is a safe space. So I'm happy to take questions and during the Q&A portion to tell you about how I navigated this, but I wanted to give a big thank you to our UCLA team and our UCLA pediatric team, and of course, our patients who keep teaching me things every day. Thank you.
Thank you to all of our speakers. This is fantastic that we actually have 16 minutes for Q&A, which is great because sometimes that doesn't happen. But thank you to all of the speakers. We have some great questions coming through the chat. I think we're trying to figure out how to address them best.
No. I was just trying to put them on the screen, but I don't think that's beyond my technologic capability. But yeah, so I think there are a few questions for our panelists and then a few questions that we might want to actually just discuss in the room that you might have better answers to. But let's start with just a very, I think, simple question. Mm-hmm. How do you handle parent requests for genetic testing for younger or half-siblings who are asymptomatic and have negative sweat tests? Parents want to know if their children are carriers, but children are too young to understand or to consent.
Your mic's on.
Yeah, they're hot.
Okay. That's a great question. And that's actually an element of my practice that's changed over the last decade plus. So certainly, in a general sense, carrier testing for asymptomatic children for adult onset conditions or carrier status is discouraged generally in professional best practice guidelines. But I do think that in the era of newborn screening, that paradigm just doesn't really fit anymore. So considering how often we're identifying carriers as a byproduct of newborn screening, I personally don't feel that it's warranted to preclude or gatekeep testing for other siblings, particularly in families that have had that experience of having one baby found to be a carrier and then telling them, we gave you this information and now we're going to say, no, we don't recommend testing your other children. Just wait till they're 18. So I personally have, I think, gotten a lot more comfortable with this as a standard practice, assuming that the genotype is fairly clear cut. It's easy to do that blood test. I generally would be supportive and work with families through that process of just the way that I would with a newborn screen, carrier positive, where we're saying, here we have some medical information about your baby that isn't going to impact them for the next 18 years. Hopefully that helps.
This question is for Siri, but I think I have the answer. or collectively in the group, we'll figure it. Does CFRI have a virtual support groups for BIPOC population? I've had a young Black patient share how isolated she feels not knowing any other Black people with CF. It would be great to have a platform to connect these patients. So I don't believe, I'm going to answer for Siri. I don't believe CFRI does, but there is, you guys might know the name in the someone in this room, the Inhale Melanin Exhale Power group that is still happening. It used to be through Retain. I've had patients attend that. Does anyone in the room know if that's still happening? Really? Nobody? That's
One hand.
We've tried to refer, I'm not sure, but
Yeah.
we've tried to refer patients. Oh, is it not on?
Should be.
Okay.
Just closer.
Yeah, we've tried to refer patients recently to that, but I think it stopped. It may have stopped during COVID. It'd be great if it was restarted.
Oh, it is. Thank you. Okay. Okay. Inhale Melanin, Exhale Power. I want to say, Rachel. It was led by a patient in her 20s with CF, an adult with CF. And I had a patient like at least 4 years ago attend, and it was very empowering for her. So I wasn't sure if it still existed, but we can get some more information about that group, and I'll put it on the listserv. And then Siri has it.
And I also will say, we used to have one support group, and then we keep adding because the community is asking us for things. So this past year, our newest support group we launched was for people who are ineligible for modulators, can't use them because of mutation, but also people who are mutations eligible but still can't use them. So that is a group where, just by virtue of what I shared before, would be comprised probably more people of color. So that's there, and yet this is another group. Hopefully that one will relaunch, but if not, that might be an area where we would then add on. Group number 10.
And
Did everybody hear that?
we can put it in the chat.
Right, perfect.
Yeah. All right. So one of the challenges that a center may encounter is a patient with known contraindications for transplant, whether it's active smoking, lack of social support after transplant. Do you recommend that we send the patient for evaluation and let the transplant team deny them, or do we keep them in-house and not make the referral based on the contraindications? I think this is a great question, and I think it's important to discuss. My answer, personally, would be educate as early as possible. Let people know transparently things that would not make them candidates, and allow them opportunities to shift those things. And so a lot of patients say, well, I didn't know there was a gatekeeping component of this, or, obviously a lot of resources are it's difficult if patients are not necessarily wanting to change, but many patients would be willing to change, and like that case presentation that found somewhere else for their brother to live, and kind of addressing some of these issues. But I would say absolutely to have them get evaluated, because we want to make sure that everybody is referred and evaluated and not gate kept by us. And so early education, allowing opportunity to change and for growth, and also yes for the evaluation.
This is for Natasha. Great presentation about Sarah. Does she have a history of substance abuse?
So no, she does not. And so that was one of the things, if some of you guys are wondering what happened. So on our team, we have 3 physicians. One of them is associated with the lung transplant team, and the other 2 are not. And so I actually conferred with one who was not, just to make sure that we were maintaining confidentiality. First of all, I spoke to my mentor, who's a psychologist, who actually delineated it, at least for psychologists, that the duty and responsibility of confidentiality is supposed to outweigh the responsibility to the team. And so you should prioritize confidentiality, because if you don't have confidentiality as a psychologist, you're worth nothing. And within our team, we decided we still didn't want to jeopardize these very precious lungs, but that if there was concern that she was going to develop substance use in the future, that further along the transplant route, there would be substance use screening that would likely identify her. So that's sort of what we decided, was that we were going to maintain her confidentiality, support her as much as possible, make sure she knows that she can reach out and communicate about these issues, so that, like Diana, we can actually problem solve before she needs a transplant. And if there is risk and concern down the line, then that can be brought up when she is actually being listed. And we can do that through tox screens and through revisiting evaluations.
Thank you. All right, let's go to the first in-person question.
My name is Hannah Ford. I'm a pediatric psychologist, and I work at the University of Mississippi Medical Center. I am the only CF psychologist in the state of Mississippi.
Wow.
I'm very used to being at the top of lists of bad things and the bottom of lists of good things in the state of Mississippi, but I did want to clarify our newborn screening. So we do DNA RMT, and we do an initial screen for Delta 508. If that comes back with 2 copies, we obviously stop there because that's confirmatory. But if it comes back with 0 or 1, we do test for 33 additional. But I really gosh, that's not great. Do better. My little call to action is our Department of Health has actually reached out to our CF team about our newborn screening and wanting to improve it. They're working really closely with our primary physician. I think they really recognize that we are the experts in the state. It's the only academic medical center there. And they've been really receptive. So hopefully next year we'll be screening for more, but I would encourage other CF teams to reach out to their Department of Health if they didn't like the data they saw there, because they have been surprisingly receptive to opening up our screening.
Thank you.
Thank you for, yes. Thank you for sharing some of the hopeful things that are happening, and kudos to you for supporting the entire state of Mississippi.
Let's go to next in person.
So I just wanted to say, based on what you were saying about the quote from the patient who's saying she just gave up and just started telling the team what they wanted to hear. And I've definitely listened to that. I work in a pediatric center at Stanford, and I have started just outright, when I hear doctors and like repeatedly in our huddles after our visits, talking about a family saying, oh, they're doing this again, oh my gosh. And so I've started for those patients going in and just asking them, how have the visits felt for you? I don't want this to feel like you're going to the dentist. And when I say that, everybody knows what I mean. Like, they always say I'm not doing enough. I'm like, yeah, sure, I'm brushing twice, or flossing twice a day, whatever. And so I've started just being very direct and open about it with families and asking how they feel about coming to visits, and if they feel like they're kind of being harassed, being told at every visit that they're not doing enough and that they're not good enough and things like that. And then asking as well about anxieties that they might be feeling when they're coming into clinic, and really encouraging them to advocate for themselves with what is important to them, and helping take it into their
hands and feel more empowered when they come into clinic with, you know, what is it that's important to you? What do you want to be working on? And let's talk about that with the team, like bring that up with the team. And that has, I've seen that really making a difference with those people who are coming in feeling that way. And I've kind of helped that with the team as well.
Thanks, Teresa.
Thank you, Teresa.
Here's a quick one that I'm just going to have you guys answer yourselves. How many CF centers have access to genetic counselors? And if so, are they embedded in clinic? So raise your hand if you have access to genetic counselors. Amazing.
That's great.
And then if they're embedded in clinic. So most of them are referrals. I'll put that also there for anyone that's attending via online.
Yeah. We have another.
Yep,
Yes.
let's do it.
We have a time for, another question at the mic.
Follow up on the group. So it was
Yeah.
through Attain Health, and they say like very boldly, like on hold until we get more funding. I know I like to email and like annoy them, like, hey, I've got 4 people in the wings, so if we all join forces, yeah, maybe. But Attain Health, they have lots of groups.
Thank you. That's,
I thought they were still going.
Person that started it has moved on. I mean, I know.
yeah, but I think Kat passed it on into the hands of some other leaders. Yeah.
All right, here's a question for, here is,
Oh, sorry, you had one more thing. Oh,
I did have a question.
sorry. Oh,
So, curiosity out of like all of you all, if you had a provider who is creating a lot of anxiety with more diverse folks, and it's very apparent that they're creating the anxiety and distrust, but they feel it is the nurse and the social worker's responsibility to decrease their anxiety, to make them adherent. I know. If you have any suggestions.
Stanford has had a large campaign for creating safe spaces at work, and the pediatrics led this like entire pediatric wide training that has, and it's not just like look at these modules and like do your Outlook on the side. I don't ever do that. But it's actually interactive where you're in a small group and you have these case presentations. So I would say finding maybe it's time for like a overall checkup. And so you're not calling one person out in particular, but you're saying, you know, it's come to attention that there are some ways that we're speaking together that may be having negative impact on our patients. And I know everybody cares so much, and that's why they're here. So maybe if it comes from the clinic administrator to say, let's all do this group process, or let's all, I would say education, but also like not targeting the person necessarily. I don't know if others have better suggestions.
I was just going to say that at UCLA, we just did the PEP training,
I was just gonna say
which I think is a good plug because, as Diana said, then the whole team is doing it. And I don't know if they have a branch that kind of focuses on BIPOC. I think it would be really cool to have that, to working with underserved minorities. But I think that was really great. As mental health providers, I think we have a lot of training in rapport building, and our MDs and RNs perhaps less so, but the PEP training gives these really good like nuggets that you can use and that clinicians can use to like make sure that questions are answered, make sure that it's a patient-centered care.
and PEP does have a great component. There might be some PEP trainers in here about looking at unconscious bias. And so that could be, if PEP training comes to your team, and that could be an area you can elaborate on.
And then I'll just speak from the patient perspective, having had interventions before where that was an issue. And part of it, it's great that the team has that safe space and the dialogue. But I have seen instances where the social workers have really worked with the patient or parent to really tease that out and then call a meeting with the broader team so that it isn't just about the social worker. And the key thing there is that it empowers the patient. The patient realizes, as a social worker, you're their advocate, but you're giving them the skills to have their voice and to model that for their kids. So I would say starting patient-centric, bring them in. We want to be heard.
And we will try to write responses to all of the other questions that weren't read out loud so that they're on the app and you'll be able to return to it. It is 9:45.
We're at time, but we thank everyone for your energy, for being here, showing up, asking great questions. Have a great conference. We will see you around. Thank you again to our speakers.